I will turn the presentation over to David A. Demora and Dr. Fred Osher. Ms. oversees the National Initiatives Division of the CSG Justice Center, in addition to working with legislators, consultants, research analysts, scholars, practitioners, and policymakers to help raise the level of public awareness about criminal justice issues. The National Initiatives Division provides technical assistance to more than 400 grantees via federal grant programs, including the Second Chance Act, the JMHCP Justice and Mental Health Collaboration Program, and Circles of Support and Accountability. Ed Osher oversees the health components of the CSG Justice Center's initiatives. He also provides technical assistance to state and local governments across the country seeking to improve the response to people with mental health and substance use disorders and are involved in the criminal justice system. We are very excited to have them both here today. And now we will pass the presentation to Dr. Fred Osher.
Thank all of you for taking time out of busy schedules to share in this webinar with us. We are building on the webinar, as Mariana had mentioned, that occurred last month. And afterwards, we had many questions that we couldn't get to, and I'm really delighted to have this opportunity to address some of them at this point in time. What I do is give just a very brief overview of the framework, sort of to bring all, perhaps folks that haven't participated in the last webinar onto the same page. And then we'll move into a question and answer using the questions from the last webinar and additional questions that you may type during the course of this discussion as the basis for our presentation. So the collaborative framework for reducing recidivism and promoting behavioral health was done under a cooperative agreement with the National Institute of Corrections, and that work was strengthened by an interagency collaboration with additional support from the Bureau of Justice Assistance and the Substance Abuse and Mental Health Services Administration. Also recognized partners in this endeavor who were there from beginning to end: the Association of State Correctional Administrators, the National Association of State Mental Health Program Directors, American Probation and Parole Association, National Association of State Alcohol and Drug Abuse Directors, who signed a letter supporting principle the concepts that are contained within the framework publication. And it was their leadership and membership that made it possible for us to get consensus of how the framework should look and some of its implications. The framework itself, we have a link that we will share with you that you can download this on. At this point in time, it's a publication that runs about 70 pages and hopefully will be helpful to you in your work. We are encouraging the audience to write additional questions, and we'll get to them as time permits. On the slide, you can see the original webinar, and that can be reviewed at your leisure following this as well. Questions, as Mariana reviewed with you, you can interact by typing the message in the Q&A box, pressing the enter key. It is also the case if you have questions after today's presentation or questions that we didn't have time to get to, please contact us at info@consensusproject.org, and we will respond to those as best as we can. The framework itself is based on a understanding of the needs of individuals with behavioral disorders moving through correctional settings. And some of the research that we reviewed in our last webinar allowed us to understand the very important concept of criminogenic risk, which Dave will review as part of his answers to questions in a moment. The thing is that many people with behavioral disorders, and when I use that term, I'm referring to mental illnesses, substance use disorder, and combinations of the two, people with those disorders end up in jail and prison for similar reasons to those without behavioral disorders, and that these reasons relate to their criminogenic needs and that one can get a criminogenic risk score. So that the very first, as a plain tool, it's important for us to understand and measure the criminogenic risk dimension. And that we will discuss in a moment as how one can do that and the tools that are there. Of these dimensions, chronic risk, mental health, substance use, we recognize that these are not dichotomous variables that you either have it or you don't, but rather that they are continua. But for purposes of this illustration, we have separated individuals into low and high risk. The next source related to the high prevalence rates of substance use disorders in the criminal justice system would be to understand for these individuals and groups their substance use needs. Again, ranked along continua from no problem, non-problematic use through abuse, and then dependence. These have specific features attendant to them and require individualized responses. But in doing so, we now have separated further our high and low risk groups based on their substance use needs. The third part would be looking at the issue of mental illness, non-addictive mental illnesses, and that they too have a range of functional impairments that are associated with them. And the severity that we're referring to is really a term that we're using to represent the level of functional impairment that that individual has. It's not related to diagnosis. It's actually related to diagnosis, the duration of the illness, and most importantly, the disability attendant to the mental illness. And through then this screening and assessment process, it allows us then to think about groups individuals that have different these dimensions, needs, and therefore should have different responses. Some of which can be delivered principally and perhaps only by behavioral health providers, some of them only by correctional staff, but oftentimes there's the need and the opportunity for collaboration between the systems. That these subgroups are not static. People move between them as they move through their recovery and have different kind of elements that are used to measure that. But this is really a system planning. It is also the case that people are more complex than these three dimensions. We recognize that. And that we, in this document, though, focus on these three dimensions as they represent some of the key issues, drivers, circumstances that are necessary to understand in order to provide effective support to the individuals that are moving through the criminal justice system. This is a system planning tool. The boxes, then, there are a series of strategies and approaches that the framework recommended, and there are case studies within the actual document itself. I just want to quickly run through these categories so that in group number one, there are those individuals with low crim risk, low substance use needs, low mental illness, and they ended up in the criminal justice system, through a unique and idiosyncratic pathway. They should do well exiting the criminal justice system, low priority for services and treatment, low intensity supervision. We know from our R&R model that over-supervising individuals with low criminogenic risk can actually make things worse. When possible, we separate these individuals from high-risk populations, and that it is the case that many of their needs can be addressed by the primary care providers in the community. Their need temporarily or moves into a category with more severity, referrals to behavioral health providers can be made on an as-needed basis. The next three groups, 2, 3, and 4, are those individuals that have low criminogenic risk, but to some degree of mental illness, substance use, or the co-occurring disorders themselves, and a low criminogenic risk population. For those of you that are familiar with the NASHBID-NAZADAD quadrant model for co-occurring disorders, our groups 1 through 4 correspond to groups 1, 2, 3, and 4 within that model. And indeed, many of these individuals have already been in systems of care in the community, and they are low risk, that means that they don't have needs that need to be attended to. Certainly that within custody, within jail and prison, there's the constitutional protections for health care, and those individuals need to get access to health care providers as determined by the medical necessity of their circumstances. In community, these individuals will get through doors dependent on resources within that community, insurance status, their ability to pay, their motivation for treatment, and as such, it's an important group for us to think about in that they are traditionally a part of the behavioral health provider networks. That they have high criminogenic risk today doesn't mean that there aren't important things that can happen within behavioral health settings to mitigate risk going forward. The group framework sorts two are those with high criminogenic risk without substance use, mental illness, or co-occurring disorders. And this is an additional population for management within the correctional system, under correctional supervision, are a high priority for enrollment in interventions which target their criminogenic needs. So they can not make the same choices that ended up leading to arrest and incarceration. They have lower prioritization for behavioral health treatment resources. They should get intensive monitoring and supervision, wrapped up pretty tight, and participate in a community program on an as-needed basis. The next three groups, again, all with high criminogenic risk, and then combinations of mental illness, substance use, or the two. The group that really screams for collaboration between correction systems and behavioral health providers. Indeed, they're a priority population on the inside for correction staff time and treatment, on the outside for supervision, and because of their needs, they need access to effective treatment and supports. Because all of these three groups have high criminogenic risk, they prioritize for enrollment in interventions that fit their criminogenic needs, and these oftentimes are under the umbrella of cognitive behavioral therapies. Within the framework, a lot of our time talking about the target population. Who should you prioritize for services? Who should get access to the resources that exist inside and outside? And we haven't focused so much on the right side of this thematic, which is the comprehensive and effective community-based services that these groups need. Again, the framework is a planning tool, and it's designed to assist them to think about how they can work together to most effectively, with the resources available, improve public safety and public health outcomes. The framework advances collaboration and communication by developing a shared language. Much of the time, we're talking about different individuals when we talk about that individual in jail or prison with a mental illness, and we need to have a more nuanced discussion of that. It helps to establish common priorities between the criminal justice and the behavioral health systems. It's not so much he's mine, he's yours with finger pointing, but ours, and think about our relative contributions to their recovery and reducing recidivism. To use the framework to create a common starting point for cross-system policies and decision-making, and we understand the importance of sharing information about our assessments, about our case plans across systems. The framework also ensures that resources are used efficiently by identifying the right people for the right interventions. We promote use of validated screening and assessment tools, and we'll be addressing that in our Q&A session so that we can understand what risks and needs these individuals have. We encourage collaborative decision-making among system leaders to think about how their scarce treatment slots, their scarce supervision services should be allocated to have the greatest impact. And lastly, the framework promotes effective practices by matching individuals' risk and needs to programs and practice associated with these positive outcomes to ensure consistency of coordinated approaches, while importantly allowing for individualization of treatment and case management strategies, and by refocusing reentry and other efforts for individuals leaving prison and jail to equip them with the necessary skills to be law-abiding and productive members of our community. So that's a very quick review of the framework itself. Encourage you on the phone, if you haven't already, to download it and read it, and keep the questions coming. This really is a basis for promoting dialogue, discussion, and planning among diverse groups of providers in our communities. We want at this point to the questions and answers, which we have grouped into categories, and we'll address within those categories at this point in time. And we're going to start with looking at the many questions that came in around risk assessment, screening and assessment. And I'm going to ask David to be the principal responder to these at this point in time. David?
Thanks for afternoon, folks. Good to hear or to see you all joining us as I look at the numbers ticking up here on my screen. These questions, as Fred mentioned, really were developed and came out of the last webinar that we did, and we attempted to synthesize them as best as we can, and hopefully we'll be hitting the major themes in terms of the questions from the last webinar. Once again, if as we're talking an additional question comes up, please feel free to put into the Q&A box on your screen, and we will do our best to be able to respond to that during the webinar today. We're going to start talking about risk assessment, screening, and assessment. And one of the questions that we received was, well, how were the central 8 risk factors identified? And so the first issue is brief recap, the central 8 risk factors again. What are they? History of antisocial behavior, antisocial personality patterns. And to be clear, personality patterns, not necessarily antisocial personality disorder. Social cognitions and antisocial associates, and those are the top 4, the big 4. And the additional 4 in terms of the central 8 include family and marital difficulties, school and problems, which might include lack of school or work, or might include behavioral problems while at school or work, lack of pro-social leisure and recreational activities, and substance use, and more specifically substance abuse. So those are the central 8, as no doubt many of you know. And they started being defined really back in the 1980s. Don Andrews and his colleagues, Jim Bonta and others, began to really look at large groups of others who were incarcerated. And one of the important things to remember is that not only did they look at the adult criminal histories and behaviors of those individuals, but they also looked at the juvenile histories. And this is important because, one, we want to be clear that this framework is not about juveniles, it is about adults, but that, two, the construct of risk, need, and responsivity has relevance to juveniles as well. And over the course of the coming year or so, we'll be really looking at how to develop a similar framework to focus on these issues for juveniles in terms of lowering recidivism. So over the course then of well over 25, 30 years, they refined their information and their data, and you can find multiple articles online and in the public domain. 2 of the more popular ones and more recent ones would be the one by Andrews and Bonta and Wormuth in 2006, and then in 2008 another one by Andrews and Gendreau. And would certainly encourage you to simply Google Don Andrews or James Bonta if you don't already have that information and those particular studies at your fingertips. Question is, well, what instruments are used to screen and assess for criminogenic risk? And I'm going to actually pull up a few questions here because they have sort of a relationship to one another, and I would like to sort of go back and forth. So what instruments are used to screen and assess for criminogenic risk? And also there are many risk needs instruments available to criminal justice practitioners, which are considered to be the most reliable and valid. So a number of things. First of all, what are some of the instruments? Well, there are a good number, but some of the most common ones utilized today include the SIR, the LSCMI, the case management version, the COMPAS, and also the ORIS, the Ohio Risk Assessment Instrument. These tools have indeed all been validated. They have all been found to be reliable. But I want to point out a few things here. First issue, the tool that measures everything. So you will find some different areas focused on slightly differently, depending on the way, which particular tool that you utilize. That's one. Two, you can use a tool off the shelf and hope to have everything work the way that you want. It's important not only to use tools that have been validated, but tools that have been validated in your jurisdiction where you're utilizing them. So what you'll see is that in these states where they are now utilizing actual risk assessment, they will work with the companies or the creators, and they will bring them into the state and they will validate them there on their population. Other tools that are out there include the Wisconsin assessment tool, for example, and a good number of others. And one of the things that we are working on is a risk assessment guide, and we're hopeful that by late March or so, we should have out for folks a review of the current risk assessment tools, what is it they measure, what combinations they might be best used for, what don't measure, and what you cannot use them for. The problem that we have with risk assessment tools is that people tend to utilize even the correct ones in a one-size-fits-all. They don't think about the population that they're utilizing the tool with and end up getting poor outcomes as a result. This is the reasons why, excuse me, this is the reasons why when you look at a number of different studies, you have different outcomes. There was a large study on the West Coast that suggested that the utilization of the compass there was not giving them any helpful predictive accuracy. There was another very large study in a very large state that showed that it very clearly did. There are multiple studies that show the LSI-R or the LSCMI is effective or is not so effective. The studies in the ORIS are fairly consistent and typically show effectiveness. You might go, well, how am I supposed to decide about that? The first issue is the development of the tool. All these tools have been developed carefully and by folks who very clearly know what they're doing. Then there's utilization of the tool. There's fidelity to the tool. There's the appropriate training of the people that are utilizing the tool, making sure that the tool is utilized for the correct populations, and making sure that the tool is utilized to make decisions that are related to the tool and not related to what the original goals of the tool were. When you add all of those things in, education, whether that's officer education or clinician education, the need for ongoing support and coaching for fidelity, the need for the ongoing training, the need for making sure that it is validated within each jurisdiction, the need to assess constantly for inter-rater reliability. You add all of those things in, you can have the best tool in the world, not get the results that you need if you don't attend to all of those other system issues in utilizing those tools. The LSCMI, are there any recommended free assessment tools that are available to the public? I've mentioned a couple of them. ORIS is probably currently one of the more, the Ohio Risk Assessment Instrument, probably currently one of the more popular ones that are open source, and it's actually very exciting to me. It's been developed at the University of Cincinnati by Ed Latessa and his colleagues, and what's exciting to me is not only the fact that it has multiple modules that you can use at different points throughout the criminal justice system, but it is open source, and we all know that we're in a time of diminishing resources. We're in a time where we are attempting to make do with tighter and tighter budgets. I was talking to a corrections director the other day who was talking about tens of millions of dollars being cut from his budget next year. In that kind of environment, we have to be very careful about making sure that we provide the right resources to the right folks, hence the issue of determining what we provide based on risk and the utilization of the correct programming. But it's also important to decide where those dollars go. And if we can indeed have both assessment tools and various cognitive curricula that I'll mention later that are open source, it really does allow systems that are more and more strapped to be able to target their dollars into things that will make the most difference and not be spread too thin. And I've actually really already responded to this in the short answer of in addressing and identifying the criminogenic areas I found or have people found the compass assessment useful. And the answer is yes. You look at what it measures, it certainly measures criminogenic risk areas in addition to some other areas. What you take into account, once again, is has it been validated on the population? Have the folks been appropriately trained? Is the fidelity to the use of the tool? And is ongoing supervision and assessment of the individuals that are making the determination utilizing the tools. With that, I'm going to switch back to Dr. Oder for a while, and I'll see you all in a few minutes.
David, appreciate it. You know what, David, there is a question here that's related. Did you want to take us with the static 99 question that's on here?
Oh, absolutely. Thank you. I somehow, when I hit the click that I didn't get to that. What's your opinion of the Static 99 risk assessment tool? Should it be used to predict recidivism of sex offenders, including those convicted of statutory rape, where community notification is then required? Well, first of all, it's sort of a mixed question. The Static 99 or the Static 99R is a sex offender-specific risk tool. It's actually more recently been updated, if you will, and there's Static 2002. Many jurisdictions still use the Static 99R because they had validated them locally and aren't yet ready to move to the 2002. Other jurisdictions and many clinicians use the 2002. It is currently considered to be clearly one of the gold standard tools out there. It is not the only tool. There's the Minnesota Sex Offender Screening Tool. It also has very good research behind it and very good outcomes. There's the Vermont Assessment of Sex Offender Risk, and now the SOTIPS, which is the Sex Treatment Intervention Scale, also Vermont, that are showing very, very high predictive rates, and in fact are coming close to matching, and in some instances even doing slightly better in terms of the under the curve of the Static 99 or the Static 2002. Should the tool be used? Absolutely. Should it be used where notification is then required? You need to separate that out. Community notification is a legal issue unless you happen to live in a jurisdiction where the notification is very specifically risk-based, in which case, of course, you would connect it. I happen to live in a jurisdiction where it is charge-based, and so whether or not you score out as high risk or low risk or moderate risk, community notification is based on what the conviction was. And statutory rape, for example, where I live, is not a statutory requirement in terms of registering. In other jurisdictions, if it's risk-based, it may be. Can you utilize the tool for statutory rape? Yes, you can, but you need a lot more detail than just what was the charge. And so you need to be careful not to fall into, am I deciding by the charge? Because charges are different depending on where you live. You need to examine the behavior and make sure that the behavior fits in, and you need to read the instruction manual and make sure that the charges and the kind of convictions that, if there are convictions, that underlie what it is that the individual has done are up to what it is that the instruction manual says. Having all of that, I make one more point. When recidivism rates of people who have committed sexual offenses, the recidivism rates are actually fairly low. I mean, there's a range from very low to mid-30s. But we look at they're not for their sexual recidivism. When you look at their recidivism rates that include non-sex recidivism, it's a very different picture. Sexual offenders recidivate for non-sexual reason than for a new sex offense. So use only a specialized risk assessment tool. Somebody who's committed a sex offense is miss many important pieces. So really very important to assess for general criminogenic risk, to assess for behavioral health need, and while we know that in most instances it is not a mental illness, even a serious mental illness, that causes the actual sex offense, we do know that in about 4% of the time it is, and we also know that there are significant other mental health impairments of many sexual offenders. At the very least, that becomes a very significant responsivity issue in terms of being able to effectively respond to their problems. If you're doing cognitive behavioral interventions with folks, they have to be stabilized of their mental health needs in order to be effectively responded to. So when you're looking at the issue of assessing sexual offenders, even for so many years we have taught the issue of specializing, and that's so important, you need to think of the sexual offending problem as the grouping. You need to see them just like everybody else we think about in the system, and then we need to add onto that this additional problem. What we've done for too long is ignore everything we know about all other types of offenders, narrow it down, and just focus on the sexual deviancy. And while it makes sense for us small group of individuals, it actually does not work very well for the majority of them who have these other criminogenic needs that need to be responded to. And then again, Fred, back to you.
Thank you. And that was response to a lot of questions that we had about the screening and assessment as it relates to the dimension on criminogenic risk. I think it's important for at this juncture, and I will turn to the questions related to behavioral health screening and assessment, to make clear the distinction between the two, screening and a simple question, yes, no, the condition exists. So might there be a substance use disorder? Yes, no. That's what our screening tools do. If answers are positive, then that requires follow-up assessment. Assessment in the mental health arena is a process. It's not an event. It takes place over time. It's the gathering up of records, interviewing the individual, putting together the diagnostic and legal pieces in the development of a differential diagnosis. So screens answer the yes-no question. Answers that are positive, screens that are positive require follow-up assessment. So the questions that we got as a result of last month's seminar is the instruments used to screen and assess behavioral disorders in the criminal justice population, and an interest again in whether there are public domain instruments that are available for each of these. A lot of factors, and David went over them in considering the selection of an instrument, and they're similar to the criminogenic selection process. We need to understand how long these instruments take, what the burden is going to be on the staff, what the staff degrees are that are required to deliver the screening and assessment, what training they have, whether they're validated with criminal justice populations or not, whether they're validated within your own jurisdiction or not. And lastly, again, several questions, whether they're public or proprietary relating to the cost of the instruments themselves. I refer people to a very good overview of this issue. It's a monograph entitled Screening and Assessment of Co-Occurring Disorders in the Justice System. Its authors are Roger Peters, Maria Bartoy, and Patty Sherman. And they do a very nice job going through the range of instruments that were available a couple years ago and what strengths and weaknesses are as it relates to criminal justice population. And so some highlights from that review in our own work, screening instruments for mental health. There is the brief general mental health screen, which colleagues and I developed an 8-question questionnaire, which sorts folks into maybe have a mental illness or not, and then requiring follow-up. And that we will put together a posting with this webinar that lists the links to these particular instruments. It is public domain. There is a mental health screening form 3. It's another instrument that one might consider. It too is public domain. And the Global Appraisal of Needs, or the GAINS SS screening tool. It is proprietary in nature, but it has some advantage in that it screens for both mental illness and substance disorders. And lastly, I'd ask you to consider in the screening instrument category the mini screen, which has about 15 to 30 minutes it takes. It covers about 20 disorders and can be useful in answering a question, whether it be a mental illness, yes or no. As it relates to screening for substance use disorders, we've got the GAINS, which I mentioned again, which should be considered in public domain. The Texas Christian University drug screen, now in its second version, is something that is used in many criminal justice settings around the country. A public domain instrument for substance abuse, the Simple Screening Instrument, or SSI. Some people use the Addiction Severity Index, which is lengthy, 45, 60-minute interview to screen and also to assess on a number of dimensions. Addiction Severity Index is a public domain instrument. What are some other factors? Now, these are the instruments, and the questioner asked if there are other factors bring individuals with mental illnesses into the justice system. So maybe just looking only at their behavioral disorders doesn't give as round a picture. Sort of make these statements in response answer that question. First, for individuals that are measure high on the criminogenic risk scales, their entrance into criminal justice, whether they have a mental illness, a substance use disorder, or not, are very similar to those individuals that do not have those disorders. So to drive people making bad decisions, violating the law, using illegal substances, these are the criminogenic needs that David was discussing earlier, and they're similar between seriously ill folks and behaviorally disordered individuals. In the crim risk group, then we have to start asking, well, if it's not those variables, why is it that there is an overrepresentation of people with behavioral disorders in the criminal justice system? I think first and foremost, substance use and substance use charges are responsible for a lot of the growth that we've seen in our jail and prison systems over the last 30 years, both as a charge itself and then as a complication, as in those individuals with co-occurring disorders who are often disabled as a result of that combination end up in our streets and oftentimes catch the attention of law enforcement, end up in our jail and prison settings. Indeed, homelessness is a associated factor for individuals with mental illness. We understand that 25% of the homeless population will have serious mental illness. This individual, very visible, might again get necessarily arrested for felonious behavior, but certainly some of the misdemeanor behavior associated with being out on the streets oftentimes brings them into jails. So the case that what can drive people into jail and prison with behavioral disorders is inadequate access to treatment, so that the disorders, and we'll be talking about them in combination, it is necessary to treat the disorders. It may not be sufficient, but as a responsivity issue, it is imperative that substance use, mental illness, and the co-occurrence of the two are treated. Treatment works. It moves people on the recovery course. It allows individuals to participate in treatment for other issues. And so not having access to care, not having health insurance, or the resources within the community aren't sufficient is another factor that drives people with behavioral disorders into jail settings. It is also the case that not having access to high-quality care. So we have a wonderful science out there with evidence-based practices in mental health, substance use disorders, and co-occurring disorders, but not everybody gets access to them. So just because you got into a behavioral health setting doesn't necessarily mean the services and treatments that you receive are the same as the science suggests gets the outcomes that we care about. And lastly, why are folks coming back into criminal justice settings is related to recidivism, and that it may not be necessarily more criminal activity, but individuals with mental disorders and behavioral disorders certainly have more technical violations that draw back into those settings. Groups is a theme that came up in the question, and that there were a series of questions about how it relates the framework to these subgroups, and a very good question about individuals with intellectual and or developmental disabilities, including those with co-occurring DD and behavioral health disorders. And know that rates of developmental disabilities within prison settings run around 10%. There is an overlap with those individuals and having behavioral health disorders, and certainly cognitive capacity is related to a developmental disability, or it may be temporarily impaired as a result of one's mental illness. Cognitive impairments are a critical responsivity issue. And so it's a great question, in that we need to screen for cognitive impairment in the population and perhaps accommodate to their needs so they can take advantage of the interventions that are associated with some of the outcomes.
Fred,
does this model take... Yeah.
I'm Fred. I wanted to add a quick thing about the issue of those with cognitive impairments as a result of a developmental disability. That too often what happens is an assumption that some of the other crim risk needs are not there, and sometimes they're not, but very often they are. They can benefit from the same type of cognitive behavioral interventions that others do. You have to adjust the programming. Obviously, you have to adapt it, as Dr. Osher was saying. But very often what happens is they simply get cut out of that there are no programs or no adaptations of the program that's being done, and they do not get that programming, which is very problematic and is much like for folks with mental illness. While it may not be the mental illness or the developmental disability that directly got that person into the system based on the evidence that we're now seeing about other crim needs, it's clearly something that's helping them stay trapped in the system because we either don't respond appropriately, utilizing the correct things, or we decide that we don't need to respond at all because we put it all on this other problem, and they end up then suffering as a result of that and staying trapped within the system over many years.
Thank you. Another question that came in was, how does the framework, how does the model take into account the socioeconomic conditions of the community being serviced? And so I think the intent of this question was to draw awareness to the fact that we are in a very resource-challenged environment in most of our states and localities these days, and that is framework sort of another unfunded mandate of some sort, and that actually the framework is resource neutral. What it is a way to design case plans, treatment strategies that respond to identified needs within the resources that are in your community. The cutoff scores that one might use to determine whether someone is low or moderate or high might be a function of what resources are available both while in custody and out in the community. The mission of the framework is let's at least understand what the needs of the population are, and that there may be a gap in the services that are available to treat those needs, but if we don't measure them, we're not going to understand the size of the gap and not be able to do a good job advocating for closing that gap in some way. So that it really is not so much an issue of what resources we have or don't. It is how do you best use the resources that are available, how do you prioritize, and we're investing within the framework, high-risk, high-need groups, which we use as a rational approach to allocate resources to reduce recidivism and promote recovery. What about homeless populations? How is housing status figured into the target population? You know, I really appreciate the question. We know that there are high rates of homelessness within our jail and prison settings, and that particularly vulnerable groups, those with serious mental illnesses, may be more prone to that. One of the federal prison inmates found 18.6% of those with mental illnesses versus 3% of those without were homeless in the year preceding their incarceration. So to a study looking at local jails, about 30% of those with serious mental illness versus 17% without were home. So, you know, we certainly on the ground are talking about some of the challenges that our communities face. It typically and oftentimes is stated that it's about the housing, and the lack of affordable housing is an issue that we understand is experienced by most communities in this country. You know, that it didn't rise as one of the central 8 factors that are associated with recidivism, maybe because of its relative low frequency among the populations that are being measured, but it certainly is a feature that needs to be understood. Remember earlier I was saying just reducing individuals to 3 dimensions, you know, insufficient. This is another one of those issues that either can be incorporated into our responsivity set practices or on its own looked at as a key barrier to successful integration into our communities and something that needs to be addressed with a case plan. It wasn't a specific part of our model in that it didn't sort of rise into the 3 dimensions that we were articulating for purposes of this discussion. Issue of trauma get integrated into the framework. Another great question. Very important. prevention. We know the extremely high prevalence rates of exposure to trauma among criminal justice populations. It is critical that we screen those individuals to understand their experiences, that we provide as best we can a trauma-informed environment to avoid some of the re-traumatization that those individuals have experienced. We need to, when folks screen positive for trauma, do further assessment to understand about whether they meet criteria for post-traumatic stress disorder, which then would generate a series of responses. Trauma is a responsivity issue within the model, and so important to understand and important to think about the appropriate responses. Thanks for that question. Dave, at this point, I want to turn it back over to you for a couple of jail prison questions.
Certainly. And, just briefly adding to the question about the homeless population, although we didn't get a question about employment in particular, the issue of homelessness and employment are typically discussed in terms of important needs to meet for folks who are in the criminal justice system, and they absolutely are. I want to echo what Fred was saying in that we don't necessarily have data to show a direct relationship to criminality, but there's clearly a direct relationship in terms of how they can assist in the future. So while it may not be the thing that gets them into the system, they are components, housing, employment, school, are components that clearly relate to sort of long-term success. I think that what happens, though, and I guess the cautionary note I want to sound about all of these things that we're saying, is that very often people choose one thing to focus on, and they make that the answer. And whether that's mental health treatment per se, whether that's a house, whether that's school, employment, family, all these are important. All of these are part of this quilt of what's necessary in terms of responding. We may not be able to respond to all of them. The more we can respond to, the better off we will be in terms of outcomes. But mostly the point that I want to make is that it's important for us to not be stuck in single issue thinking, and the idea that there's a silver bullet in terms of these series of responses that will make the difference, because everything that we see tells us, not surprisingly, that it's more complicated than that. Now, my guess is that of the 195 or 200 people that are on this webinar, the vast majority of you know that. But I would also argue that the vast majority of our systems don't effectively operate in that manner. And so, though many of us do know that, we are still, I think, working hard to get policymakers to understand what is necessary in terms of doing that. And we're going to mention a few states as we get to a few other questions here. In terms of framework applications in jails and prisons, well, first of all, to recap, the framework was originally developed in conjunction with the National Institute of Corrections, which were the original folks, and then the Bureau of Justice Assistance and the Substance Abuse and Mental Health folks joined in as well, understanding sort of the importance of this framework. So it was originally developed as a tool for correctional administrators, and so much of the way that we've talked about it are certainly talking about post-conviction, certainly talking about people who have been incarcerated, who at some point will be released into the community. I do want to, in particular, in response to one of the questions that I saw put across my panel, if you will, as Fred was talking, one of the things that we are very clear about is that while the initial application of this is focusing on what's going on in prisons and in facilities and post-conviction into the community, that we're very clear that it plays a role in trial as well, that it plays a role in looking at how people get into the system, how they get stuck into the system, how they might spend more time. They're more likely to get incarcerated in jail pre-trial, more likely to spend more time there. We do understand all of that, and while this framework was not initially specifically developed to focus at that level, we have very quickly begun to realize and to understand that with some as we will be doing over the course of the next year and testing this out, that it can play a very big role at the front end of the system and really help keeping folks from getting involved in ways that are not necessary. They get involved in the system not because of the risk of the community, not because of community safety or risk of recidivism, but simply because of the difficulty in terms of mental illness or other particular problem that are facing. Now, one of the questions was, has the panel recognized issues related to those with serious mental illness and the access to drugs within prison, which many use to self-medicate? And, the answer is yes and no. We didn't specifically focus on that issue. We all know that there are different types of difficulties and problems in different prisons and jails, and that's just natural. I think the larger issue is less the issue of whether there's access to illegal drugs, which of course we would prefer was limited, don't misunderstand me, but that the real issue is what is in place, in the facility to respond to the needs. What is the system in terms of assuring that there is medication, assuring that individuals are treated as necessary, and that they have access to those services, and that those services are not dependent upon risk, as some other questioners asked last time, and which I'll come back to. But one of the things that folks wondered is, well, when somebody's really high risk, they often get into these segregated settings, and then they have access to the mental health unit, or they aren't able to see the folks because they're not allowed out. That is very much a systems problem. It's very much an issue not of, oh my goodness, they can't have those services. It's an issue of those services need designed so that depending on where the individual is, they're available. Maybe they can't go to the mental health center or setting, in the prison, but that doesn't mean that there can't be something structured so that the clinical folks are going to that particular unit. Some states have developed separate facilities specifically to deal with this. In Connecticut, for example, there is one facility in particular that is designated for folks who have serious mental illness, and so it is structured in a way that really focuses on the problem and resolves it. It does not determine people coming there based on risk. What they do is they decide how people are housed within the facility based on risk, but regardless of that, they still are going to receive the necessary mental health treatment at that facility. Now, having said that, there are clearly far more people in the prison setting than most places have developed in terms of a facility or even two. One of the questions that related to that was this issue of and talk about building or changing prisons and jails into mental health facilities. Certainly is not much talk about building. Obviously, we're in a time of just reinvestment. We're in a time of actually trying to have less folks incarcerated and to have as many facilities. There certainly is thinking and talk around the country about how to better utilize the prisons that we have, how to better structure them in terms of providing necessary mental health and other services. Some places have done better than others. Needless to say, some places have done very little. There are a number of states that have done variations on having a facility, as I just mentioned, and there are others that have done better in terms of having more units or more services available in a wider variety of prisons. We tend to see that being a little easier than in jails. Why? Your turnover is not as quick, right? You don't have as many people coming in and out. They're there longer. You have more folks, obviously, there post-conviction. With the in some of the fight systems, you'll see that mix, but in most other systems, you will not. You'll see the pretrial folks who have very, very many needs themselves in the jails, and so typically the turnover will be significantly greater than what you would see in prisons. So is there thinking about it? Yes, there's big interest. There have been lots of discussions and contacts over the last couple of years in terms of focusing on this, but it's happening at the same time as there are massive cuts, and so that can get in the way. It's also happening, I think, as people are just beginning to figure out this nexus of criminogenic risk and mental health or behavioral health, mental health and substance abuse need, and it's, I think, thrown folks a little bit in that they're now revisiting and relooking. I was talking to another corrections director today we were actually talking about the framework and doing some work interstate, and it was very interesting. He said, I kind of knew this stuff. It's not that this isn't common sense, but it just wasn't going together for me in terms of making sense about how to think about it structurally. We've blown up the chart that Dr. Osher was talking about. We've blown it up, and it's on my wall, because that's what we need to look at in terms of thinking about to structure what we're doing in our institutions and determine what we're going to do, how we're going to prioritize the services that we do. And so it was a kind of fun, not surprising probably to most of you, kind of a fun conversation to have, but also exactly the kind of thing that we hope for, that really is the way that it needs to be thought about. Not what's this facility going to do, but how is our system going to respond to this issue throughout all aspects of the system. For application, another question that came up was, criminal risk is, of course, different from custody and classification security levels. Needless to say, classification levels within a facility, particularly relative to maximum security and disciplinary inmates, often determine treatment delivery and access to these more intensive services. If the inmate is classified as high security, then his movement to the facility is limited. How do they get access to services, especially since many of them may have higher criminogenic needs? And as I really started to mention earlier, that again becomes a systems issue. Of course, if there's a classification reason that somebody's movement needs to be limited, if they're more dangerous for whatever reason, it's extremely important from a management perspective to ensure that all of the necessary things for the safety of other prisoners or the safety of guards and of other staff are matched. That doesn't mean that the system cannot be structured in a way to get those services to those individuals. It's back to that sort of single issue or silo thinking, as one of the other commenters wrote in. Well, we'll solve this problem, and that's what we focus on alone. It has to be focused on in concert. It does not cost more to have two, and I'm making a number up here, but it doesn't cost more, for example, to have two clinicians spend 2 days a week on the more intensive unit where folks cannot leave than it does to have them next door or down the hall in the regular mental health center. It's an issue of it costing more. It's an issue of really thinking about what are the necessary services to provide and how are we systemically going to put that in place. Corrections officials decide an offender is high risk and needs intensive monitoring. They're often sent to intensive management unit, called by one CO a prison within a prison. How does this promote goals of meeting safety and needs? I think this is, again, variation on the previous question. I think that it's very important that we pay attention to what are the safety needs within a prison, however people define that. But it's also very important for correct systems to understand that they play a central role in recidivism reduction. And in fact, more and more corrections directors are beginning to understand this. There was a national forum just about a year ago that resulted in the BJA putting out a number of recidivism reduction grants to states. They awarded it to 7 different states, and specifically to corrections departments, who realized that what they're doing behind the walls is part, certainly not in total, but is part of what is necessary in terms of lowering recidivism, and that they really have committed to focusing on what they're doing in terms of programming and management to make that difference, to help play a role in the drop of recidivism, that it's not only what happens when folks return to the community. So I think the question becomes less, should we or shouldn't we have some place for more dangerous folks within the prison? It becomes, how do we build the other things that we need into the system, even when we need to separate folks for very, very real reasons and not have them in the general population or with lower risk individuals. Another question that came up is, excuse me, I've got great respect for the doctors and treatment teams that work with offenders. Many people after the release, due to problems as not receiving 30 days of medication or prescription or being released back to the same environment. How to communicate these issues to those in charge of policy development? There's a number of potential responses to that question. I think that the first one, of course, is, are you assessing folks accurately so that you have the information to share? The second one is, do you have a way to collect that data, to collect that information so that you can give that to folks outside your system, policymakers, starting internally, of course, right, all the way up to the top, the corrections commissioners, and other folks that you would be working with, directors of probation, parole, et cetera. But then also, is it then packaged in a way that somebody who doesn't work in the system can understand it? Again, at this meeting that I was at last year, it was very interesting because we had the folks from corrections and we had their champions, their legislative champions there as well. And one of the things that the champions were saying is that, we get a lot of great information from the corrections folks, but we don't know what it means. We don't understand understand. So we get 200 pages, we get 300 pages, but we can't interpret it in terms of what it means we need to do. And so part of the issue becomes what are the policies that are developed in terms of people being released? And in order to get that in place, you have to be able to show folks why it's a problem to not have medication upon release, why there needs to be a prescription before that. And I might add, by the way, that more and more correction systems are indeed providing 30 days of medication upon release. And that is a very step in the right direction. Where it falls down, though, is in the connecting to the community services. So they get the 30 days. That's much better than what we've had before. But what they don't get is effective access to services within 30 days so that they can continue the necessary treatment that they have. And so part of what is really very helpful is to make sure that you start having some in-reach from the local providers, having them come in to see folks before released, or if you cannot do that, make sure that the supervision agent is getting involved early and that they act as the bridge, if you will, between what's going on in the prison or in the jail and what happens in the community. And a number of different services that are being developed, or processes probably is a better way to put it, that are being developed right now, one of which is a NIATEX process, which looks at the effectiveness of getting folks into treatment and referring them in an appropriate way, having the right connections, doing it in a timely fashion, making sure that they get where they need to go. So sort of process improvement or quality improvement processes out there that it might indeed be worth examining further. And if folks are interested in what I was just mentioning, one of our staff folks is very involved with that, and if you want to write us at the info address that is on the webinar, we're happy to get some information back to you. How much an inmate tells me they do not want to be law-abiding. For example, they want to continue smoking pot, which is very common in my area, where pot is a leading economic activator. Don't know where this came from, and may indeed be an activator. I think the larger issue here is probably, well, what about folks who really are motivated to do the right thing? Well, a number of things. One of the things that we really haven't talked about yet is what are some of the best responses. But one of the more and more common responses that's being utilized these days is putting in place the motivational interviewing. And the construct of motivational interviewing really helps individuals work with folks in a way for them to determine why it's better for them to be doing the right thing, as opposed to what we think they should be doing the right thing. And that's a grossly simplistic explanation. But fundamentally, it comes down to that. What's in it for the individual to be law-abiding as opposed to not law-abiding, as opposed to why do we think the individual should be law-abiding? It's a helpful response. It's not the only response to do. That brings us to the discussion of programming in terms of interventions, and there's a couple of questions about that, so rather than just jump into that, let me wait a panel or two and come back to that. The question that came up was the issue of updated national recidivism and revocation rates that we can share for offenders categorized as moderate, high risk, and SMI. And another one, what national or state-based recidivism rates do you know of for the highest risk, highest need enrollees with serious mental illness? Well, we don't have a national rate per se. There are tremendous variations throughout the country. You see ranges anywhere from the high 20s, low 30s, up to the 60s and 70s. And so there's tremendous difference state by state. Pew put out a very good report looking at the various states, and you can get that by going to their website, Pew, P-E-W, and take a look at what it is that they have found in their study. But I found some interesting things. Even though the rates are over the place, more states are very much focusing on lowering those rates and then doing the necessary things. And in September, we actually also put out a report about states reporting reductions in recidivism. And very quickly, just to mention some of these states, Kansas, and these are change in rate between 2005 and 2007, And we hope in the next year to be able to give you some additional, even more updated data, But as always, of course, it takes a couple of years to be able to determine what the numbers are. But Kansas has dropped its recidivism rate by 15%, Michigan by 18%, Mississippi by 9%, Ohio by 11%, Oregon by 8%, Texas by 11%, and Vermont by 6%, just for example. Now, those are mostly pretty impressive rates, quite frankly. But secondly, and I would urge you to go to the Center website, take a look at the report in full. It's important to understand that there's both the issue of percentages and the different sizes of the systems. And so it's possible in some places that a small percentage is actually a much larger number of individuals than in others. So you need to look at both of those. But what is the theme? The theme is clearly states focusing on lowering recidivism and a number of states having success in doing that. And we break it out specifically by SNLI, by folks with serious mental illness. For the most part, we can't, although Wisconsin has done some interesting work around this. And Fred, you want to touch it just briefly?
I think that what we saw is they categorize the prison population in 3 levels: not having a mental health need, minimal need, and then a significant need. That the 2 follow-ups went as one might expect. Those with the highest mental health needs had the higher recidivism rate. Those without, lower. So, again, we also, from a study done by Jen Scheme and Loudon, know that individuals with serious mental illness do come back into jail and prison at higher rates. Again, not so much for new charges, but for technical violations that lead to their revocation. So there is a suggestion that those individuals with serious mental illness are certainly in need of strategies and interventions that would assist them beyond mental health treatment in staying out of custody.
Thank you, sir. We received a question about are there cities looking at evidence-based programming in terms of demonstrating its effectiveness for lowering recidivism? And the answer is yes. The long answer is a lot of them, and it depends on what you're looking for. You can look at many studies, for example, done in the state of Ohio by Latessa, Lowenkamp, and others. You can look at the studies that Fred was just mentioning by Jen Scheme out of UC Irvine, and very much show that programs that have a cognitive behavioral component to it, some of the curricula that are out there, such as Thinking for a Change, Reasoning and Rehabilitation, Moral Recognition Therapy, clearly have an impact in terms of lowering recidivism. The best way to think about programs and recidivism, though, there are 2 websites now that you can go to that will give you some very good information or some excellent information looking at this. One of them is the What Works in Reentry Clearinghouse. And What Works in Reentry Clearinghouse is a website focusing specifically on the issue of reentry and then looking at different components within reentry. For example, what employment programs have been shown to be effective, what substance abuse programs, et cetera, et cetera. So I would urge you to Google What Works in Reentry Clearinghouse, and you will get our Justice Center website, and it will bring you directly to that. The other website that's very important to know is crimesolutions.org. crimesolutions.gov. And so Crime Solutions, one word, .gov. And again, this is a website that focuses on what are the effective programs that are out there. And it's not focused just on reentry. It's focused in sort of the larger criminal justice arena. And you can look there and find programs that have been shown to be effective, shown to have be highly effective, have some degree of effectiveness, have no impact, and also some that perhaps actually worked in reverse. And that, I have a question here, which is, there are particular states who have proven programs to consider for replication of effective community-based interventions. There's a number. We'll just mention briefly three. I'll mention two, and then Fred will mention the third and move into taking over the rest of the slides. But one is Ohio. As I've mentioned several times, and Ohio has done a tremendous amount of work focusing on the services that they provide in the community. What they found was that in many instances their programming, including the more expensive residential programming in the community, was not only not lowering recidivism, but was increasing it. And they found that this was because they weren't determining who was going in based on the level of risk and the criminogenic needs that they had. And when they broke it out, what they found was that these programs were actually increasing the risk of the lower-end folks in terms of risk. And they were doing actually a good job with the folks that were moderate and high risk, but that because they were doing so poorly and increasing risk with the low-risk folks, that their outcomes ended up being very poor. They restructured what they were doing throughout the community, changed how it is that they were providing the services, in some cases who were providing services, put in place a lot of quality control measures and evaluation processes for accountability, and really have moved tremendously from providing services that were not necessarily bad services, but were not the right services for the right people and the right dosage for the right length of time, and really changing that. And it's clearly one of the models in the country. In Connecticut, we have for a number of years, and for those of you that don't know, I live in Connecticut, though I work in New York, we have specialized mental health units in both our probation and parole divisions, and they have been successful at working folks with mental illness, including serious mental illness. We have a trial diversion program, and we have, interestingly enough, some residential programming and day programming that's funded in part by corrections and in part by the Department of Mental Health for folks who have mental illness, to either keep them from going into prison during a pretrial scenario or getting them out into a safe environment if they indeed have been incarcerated for whatever reason. And these officers are specially trained. They receive ongoing training. I work very, very closely with the community providers and both the community providers in terms of the providers who do the traditional criminal justice criminogenic risk response, and the mental health community providers. And the mental health community providers and the criminal justice community providers work closely together with the population. And the third state is, again, Wisconsin, and with that I'll turn it back to Dr. Osher.
Thanks, David. And the questioner is looking for where are people doing this better than otherwise, and do we have data to support the effectiveness? Wisconsin is a state that has an innovative program focused on high-risk, high-need individuals, serious mental illness with co-occurring disorders, criminogenic risk, leading their Department of Corrections, and the project initially has them going to a couple of jurisdictions in the state. They have developed a lot of innovative and I would think consistent with our evidence-based principles. In-reach occurs from community providers to the prison prior to release. There are cognitive behavioral interventions that the prisoners are started with, which are continued into the community. There is a multidisciplinary team with collaboration between the community corrections officers, behavioral health providers, releasing authorities at the state. It is comprehensive in responding to both the needs and associated other factors. Housing, as we had discussed earlier, for some a key factor with individuals getting access to affordable housing in the community. It's a collaborative venture between Department of Corrections and Department of Health Services. And while it is only in its infancy with 100 or so individuals that have been released, their recidivism rates are extremely low with this collaborative, constructive process focusing on addressing criminogenic needs and behavioral health needs. So there are models out there. I'm sure the attendees on this conference call webinar have other examples, but we are interested in applying the evidence-based practices to achieve these important outcomes. We only have a few minutes left. There are a bunch of questions about paying for services and the Affordable Care Act, and so I want to run through these very quickly. Who should pay for the needed services? Well, In custody, the answer is one, that there are constitutional protections for health care, as we're aware of, and so there is an obligation for Department of Corrections to provide these services. They're in circumstances where programming isn't sufficient for numbers. The firm suggests that prioritization on those with high risk is appropriate within those settings. Out of custody, it is the usual and customary services that are available within the community. And again, realize that in resource-stretched environments, not everybody that needs it is getting access to it. Sometimes it's related to insurance status and ability to pay. I'll address that in a moment. Sometimes it's related to not meeting the eligibility criteria for existing services. So all states actually have definitions of priority populations for mental health services, serious mentally ill, serious and persistent mentally ill, which determines access to many of the public funded services there. Individuals that may not meet the criteria, they fall into this pool which we call gray area. Have needs, no way to pay, and there may at that point in time be a case to be made for those in that population, gray area, with high risk, that may be a time where correctional resources can be used in a targeted way to get them some of the services they need to address both their criminal risk but also their behavioral disorders. How might the Affordable Care Act impact justice-involved populations? Well, it, being on your state, could have a significant impact. As you know, justice-involved individuals, many of them are low-income adult men, and heretofore have not qualified for Medicaid unless they met some stringent eligibility and disability requirements and are unable to work. This left and leaves many of those correctional settings without insurance. Starting 2014, under the Affordable Care Act, household incomes at or below 133% of the federal poverty level will allow an individual to be eligible for Medicaid regardless of their disability status. So we believe that a large number of individuals in states which are moving forward to expand the population, a large number of folks exiting from our correctional settings will be eligible for Medicaid, and with that will have access to a range of services to be defined that can be very helpful in addressing the responsivity issues and also in slowing the revolving door, reducing the frequency in which they come back into correctional settings. Will citizens receive federal Medicaid reimbursement for health services under the ACA? No. ACA doesn't change the current reimbursement policies, and that when an individual is in a state-run, county-run facility, the Medicaid dollars that might be accessed to match their community services are not going to be available to them in those facilities. However, we do know that within the ACA, the pretrial detainees, those folks that are not on a sentence status, are still eligible for access to the Medicaid if they meet the income requirements, and that we ought to be thoughtful about how to identify those individuals and support their application and then enrollment in the Medicaid program. Next question related is, will the ACA open eligibility to inmates placed in work release facilities to qualify for community-based services? So I want to borrow an analysis from my friend in Oklahoma, Bob Mann, who refers to the pillow rule on this particular question, that being, where does that individual lay their head at the end of the day? And if indeed they lay it in a government-run, involuntarily managed facility, that they're not going to be eligible for the Medicaid reimbursement that they will if they lay their head in not their own residence within the community. So the answer to this, I think, depends on whether it is government-run and voluntary or not. Next question related to health resources is the interrelationship between behavioral health conditions and physical conditions and its impact on individuals' compliance. And a another great question out there, in that we know rates of physical illnesses, sexually transmitted diseases, chronic obstructive pulmonary diseases, a host of medical illnesses are highly prevalent in this population and co-occur with individuals with behavioral disorders. And certainly those physical health conditions that could impact an individual's ability to participate in treatment, cognitive behavioral interventions, or the behavioral health treatments themselves need to be addressed. Physical health conditions are, again, a part of those responsivity issues that we have been addressing. What will justice agencies be doing now to maximize the impact of the populations? First and foremost, they need to get a seat at the table. Okay, so those in the audience that are correctional administrators working within departments of corrections need to understand what process and what stage in the process your state is in designing their response to the Affordable Care Act. How are their health information exchanges being set up? How they be accessed? I think that one in custody issues to consider would be assessment and identification for people entering of their current status, and if not on Medicaid or some insurance plan, what their eligibility for it might be, and if eligible, figure out the application process so that when they leave the facility, they can hit the ground running with access to important health services. So it's a very exciting time for all of us in thinking about improved access to health care services, mental health, substance abuse, psychopharmacology that may be afforded to the new eligible expanded population under the Affordable Care Act regulations. We have a variety of publications that has been referring to, and here we have our link for you to both find the core document that we've been discussing today, but also a lot of the ancillary materials that we've been referencing throughout the course of this webinar. And the information and these websites, and as I mentioned earlier, will the post-webinar put up a list of the references that we used during the course of this discussion so that you can follow up with them at a later date. We managed to take up our available time with the old questions, and we have a whole bunch of new questions. I'm going to turn this over now to Mariana, who will talk a little bit about how the new questions might be handled and close the webinar at this point in time. Mariana?
We have received so many questions. David?
Actually, I was just back channel here talking with Mariana, and to see if we needed to close down exactly at 3:30 or whether we would be able to go an extra 10 or 15 minutes. I'm noticing that virtually everybody is still signed on, and so my thought is that we might go another 10 or 15 minutes to try to answer at least some of these questions, and I'll keep an eye on the number of people that have signed in, and as we get a significant drop-off, we will certainly wrap up and end. And this is, of course, assuming, Fred, that you might have another 15 minutes or so as well.
Sure. I think we should be mindful of people's schedules, and again, a significant drop-off. There will be folks that won't get questions answered that they want. So in addition to a few more minutes now, we also will have a mechanism to address these going forward. Are there particular questions, David, Mariana, that you want to take the time to address?
I received a number of questions addressing sort of the same idea, which is that the criteria in the framework change over the life of a sentence. So like consumer substance abuse or mental health status may change over time, and a lot of people are wondering, how do you account for these changes over time? Should people be in different sets of programs according to that? If their risk level changes, how do you deal with that?
Yeah, they're good questions. I'll take a stab at it first. I think that it really is important to be mindful that this is a framework itself is a system planning tool, that it is a snapshot, of your system at any given time, that will indeed do move for their recovery and access to treatment and changes in status in different categories. Always, it is the individual assessment of the dimensions and the other critical ones we've had during this course of the webinar that used to determine the case plan and treatment plan, and those need to be assessed and then recalibrated to the changing facts on the ground. So this isn't meant to put a person in a box and keep them there forever, but rather to show you some of the principles that might be used to guide the appropriate levels of supervision and then the necessary treatment access for that person.
Also a number of questions related to the issue of can the risk assessment tools be used with both men and women, and the answer is that it depends, that many tools will have a component to them that can be utilized. So for example, the LSI has an add-on, the ORIS can be utilized, the behavioral health screen that one of the behavioral health screens Dr. Osher was talking about can be utilized for males and females. There are also many other tools that cannot be utilized for both males and females, and certainly the sex offender assessment tools are for males only. So you need to make sure when you're looking at the tools to specifically look for that issue of whether or not it is only for males or if it can be utilized by itself or in conjunction with some other tool for females. And I think that the other series of questions that I think continued to see the issue of how to address the issue, and Fred, I'll put this one to you. How do we address the issue of improving consistency between what occurs within the institution and what happens when they move into the community? And I think we will use that series and this answer as the way to wrap.
Well, certainly a critical issue for all of us to be mindful of, that we have opportunity while people are within custody to provide essential rehabilitation treatment services to them, and that the continuity from inside to outside is critical. We know that the most vulnerable period for individuals leaving correctional settings are in the first few days and weeks upon reentry into the community. And some of that relates to the fact that there were supports and services that they got inside that may or may not be available once they leave. It's also important that there be a consistent message in services that are on the inside for those that are on the outside. That was in part one of the values we felt of the framework, is to get people on the same page with language and terms and jargon so that they can begin to plan for the continuous care and the prioritization of those individuals. So I think the questioner has really touched on a very, very important part to this. People with behavioral disorders have those disorders for long periods of time, some of which they spend in custody, most of which they don't. And we'll be mindful about the relative roles and contributions that we as providers in various settings can make at different points during the course of individuals' contact with us, and that to the extent we can be consistent, that our messages are clear, that our interventions are evidence-based, then we're more likely to get those outcomes that we all value and for so deeply. So, very much.
I'd like to also thank everybody, and I noticed that there are still a number of questions, and what I would just ask is that if you would indeed like us to respond, please simply cut and paste your question and send it in an email to the email address that you were given, and we will be happy to respond to that. Thank you all, and there's still a tremendous number of you that are signed on. We very much appreciate that. Mariana, any last words?
I just want to thank you all again for your attendance and participation, and thanks especially to the Bureau of Justice Assistance for sponsoring the event, and thank you especially David and Dr. Schroeder. I want to remind everyone that a recording of the presentation will be available online early next week or later this week on our website, which is www.consensusproject.org. If you would like to send an email to the presenters, please email info@consensusproject.org, and we'll be sure to follow up with you. Lastly, when you leave this event, a brief survey on this webinar will pop up on your screen, and we would very much appreciate your feedback. And so thank you, everyone, and we hope to see you again soon.